Welcome to the healthmanagement.org DigiConf. Human Matters. Healthcare workers, patients and families. Our IT Editor-in-Chief, Professor Werner Leodolter, is moderating the session. Our panelists include Mette Atipei Craggs, Specialist Consultant at the Centre for Telepsychiatry. Erik Van der Eycken, EU Research Projects Officer at GAMIAN-Europe. Professor Dr. Stefan Heinemann, Professor of Business Ethics. Begoña San José, Consultant and Clinical Psychologist. Dr. Sara Saeed Khurram, Co-founder and CEO of Sehat Kahani. And Adjunct Assistant Professor Habeebul Rahman, Head and Senior Consultant at Psychiatry Department at Tan Tock Seng Hospital. Let us now welcome the moderator of today's DigiConf, Professor Werner Leodolter.
Well, we are all together living through a period of COVID, and that's a period with limited human interaction. And I think it's a very good idea to talk about human matters in this context, because it's on the one hand, it's when you take human matters as a noun, then we put the human in the center, and all our panelists will talk about that. But we also experience that how COVID is pushing digitalization, how doctors are ready to use that, who have been very skeptic before. And together with this digital transformation we are going through, we experience that artificial intelligence is coming more and more to us in our daily life. We already can use it. In healthcare, it's not so far. But when you take into account that in healthcare, we take decisions for patients that decide over life or death, then we have to face that we have to be very cautious here with the use of digitalization and of artificial intelligence with artificial intelligence in focus. So I think that's where human matters in terms of a verb. We have to look and we have to make sure that the human stays in the driver's seat, and that artificial intelligence stays as support function and not more. So in this collaboration with artificial intelligence, we have to make sure that human matters in terms of a verb. But after this opening remark, we can discuss it after the panelists in the following discussion. I would like to ask our panelists to give their presentations. When you have, as audience, urgent questions that you want to ask immediately after a presentation, then please put it on the chat. I will bring it to the panelist, and finally, in the end, we will have a moderated discussion. So we try to end up until 5:15. So welcome my panelists from all over the world. And I think that's really a good sign, and that there are so many female panelists, because as I come from IT, it's astonishingly low female presence. But I think we will hear a presentation on this topic today. So let us start with Mette. With Mette Atipei Craggs from Denmark, from the Center of Telepsychiatry in Odense, and we are very interested in your presentation. Please take over.
Thank you, Werner, and thank you for this opportunity to discuss this important topic and to bring in the perspective of digital mental health. As Werner said, I'm Mette Atipei Craggs, and I represent the Center for Telepsychiatry in the region of southern Denmark. We are a research and innovation center working as part of the regional mental health services. We support digital innovation for mental health and well-being, and we do this by developing new digital services, validating their effectiveness, and delivering them as running services. So we cover development, implementation, research, and service delivery. And why do we work with digital tools for mental health? Well, provision of mental health services is facing a number of challenges in Denmark and on a global scale. These include increased prevalence, treatment gaps, and discontinuity of care, for example. And just for reference, these were already important problems along with others before the pandemic, but let's just say that they haven't exactly improved during this time. So basically, digital tools for mental health are about increasing access and improving mental health outcomes for people with mental health problems. And what the digital tools can offer includes the chance to promote mental health and intervene at an early stage. They can also improve access to quality care and support and enable self-management. They can allow for greater continuity in service provision through data sharing between the patient and the provider and between healthcare sectors. So just a few examples. And to recap a bit the article that we contributed to the Human Matters issue, I want to touch upon a few main points. The key benefits of digital mental health services as we see them are accessibility, flexibility, and adaptability. For the services to improve care, we have to find the right balance and be agile. This is why we're working towards a stepped care or matched care model, allowing us to match the level and nature of care to the needs of the individual patients. As a starting point, we're aiming for 4 steps, with the bottom step consisting of information and tests, and the top step consisting of blended care. In between would be unguided and guided self-help tools. And at these different steps, we would offer different services, some of which would be standalone services only active at one step, and others would span several steps in different versions. One of these is the ICBT clinic, internet-based cognitive behavioral therapy clinic, which is run from our center by a team of psychologists. The clinic treats depression and a range of anxiety disorders through online cognitive behavioral therapy, supported in writing by a psychologist. This clinic, which serves the whole country, will form the basis for important development work in our efforts to offer stepped care. And to make this happen, we're looking into developing unguided treatment and treatment for a broad range of illnesses, and this blended or hybrid treatment format, including in-person encounters as the very top step. Other services include the Mind Helper website, which offers information and support to young people struggling with mental health problems. This is completely asynchronous and available at all times. It's also a very low threshold service, so it's something that would be placed at the very bottom step. Another one is video consultations, which of course is in the synchronous category and has been heavily impacted by the pandemic. So all in all, digital services have been a vital part of how we have managed the COVID-19 crisis. When the pandemic hit us, we saw an immediate rise in the use of tele and video consultations. And at the same time, we had to implement a new solution to be able to handle the demand that we saw. This implementation process had already been planned as an on-site process, which now had to be carried out virtually. So that was a whole challenge in itself. And in this situation, it became clear that support, as in technical support, and training and a network of local contact persons was key for success. So our focus now is to sustain the beneficial aspects of digital services that we've seen over the last many months. We very much see the way forward to be the asynchronous format, independent of time and space, as well as this stepped or matched care in combination with, for example, face-to-face encounters into the hybrid care format. Introducing digital services can add this extra layer of choice and personalization, and hopefully free up critical time for in-person care, for example, for complex cases or bringing down waiting times. And of course, they're not the answer to all of our problems, and there are plenty of challenges ahead of us, not least in trying to ensure health equity and minimizing the digital divide. This includes improving digital skills in both caregivers and patients, and not just how to work the technology, but how to work it well and confidently, and establish the necessary therapeutic alliance between the clinician and the patient. So to sum up, mental health affects us all. And this is more clear and getting more attention than ever now because of the pandemic and the way it has impacted our lives. It's not new to us who work in mental health service delivery, but there's no doubt that there's a greater focus on the topic than there was pre-pandemic. And in collaboration with our partners, including GAMIAN-Europe, also present in the Human Matters issue and here today, and EHTEL, the European Stakeholder Platform, we want to learn as much as we can from the experiences of others and collaborate to improve mental health care through digital solutions. And that's all from me. Thank you.
Thank you very much for this presentation. I think it proves once more that Denmark is a leading country concerning the application of digital technologies in healthcare. And as far as I watch it from far away, Denmark has made its homework concerning the structures, and that enables you to be so innovative in using that. So congratulations for that.
Thank you.
Are there any questions in the chat? Let me have a look. There was one question about the availability of the recorded of the record of this session. It will be available as you see it. So no questions concerning the content. We'll come back to these themes in the discussion. So the next would be Erik Van der Eycken. He is focusing on the challenges of e-mental health in Europe. And so it suits perfectly after your presentation. We are curious, Erik. Please start.
Yeah, good afternoon, everybody. I hope that my interconnection is well enough. We had a few issues, but hopefully you will hear me throughout the whole talk. First of all, thanks to Mette that she has announced me already a little bit. I'm a representative of GAMIAN-Europe, and I'm also a person with a lived experience in mental health. So I would like to give a few words or a few ideas, thoughts about e-mental health and the patient's perspective. And let me start by saying to you that there are approximately 300,000 e-health applications worldwide. I found it somewhere in the literature, and about 20,000 are about e-mental health. Now, I've put all these different apps in different categories, such as already mentioned by Mette. You have the interactive, you have the passive applications, you have serious games, you have virtual reality, augmented reality, chat platforms, and probably also some other classifications. But the objective of my talk is, of course, as I mentioned, to focus on the e-mental applications. And now, in addition with the previous categories that I mentioned, I also make a distinction in the e-mental health. I make a distinction between e-mental apps, on smartphone, iPhones, laptops on one hand, But on the other hand, the telepsychiatry applications on the other hand. So these are the applications such as video consulting and interactive synchronous therapy using the internet-based communication technologies. Now, to my understanding, I think it's not only my understanding, this telepsychiatry is the most related or the closest to what I would call clinical care, and more particular to outpatient care. Now, the whole area of e-mental health can play also a role in the entire healthcare care service, going from data management, prevention, resilience building, diagnostics, even to a certain extent self-diagnostics, treatment, effective measurement to supportive therapy as a part of an aftercare. Now, it is quite evident, and I think we all know, that the purpose of e-health is to establish an increased accessibility to normal healthcare when the conditions for normal type of care are difficult. And I think no need to say that there is no better example of this than the current COVID-19 pandemic. Now, the preventive e-mental care can occur in various forms. For example, websites with psychoeducation, self-tests, and even treatment programs with or without professional guidance. Now, the key in this is offering a low threshold online help at an early stage in order to prevent emerging complaints from developing to serious mental health problems. But e-mental health tools can also exist of real treatment programs, I would say. For example, you have a depression treatment program based on computerized cognitive behavioral therapy, as already Mette mentioned before. Now, this internet-based treatment can be offered with or without intervention of a caregiver. Now, in the early introduction of e-mental health, the focus was mainly on programs without interactive support of a professional, what I call the self-help programs. However, it was seen that therapy compliance turned out to be low, and many clients dropped out halfway through the process. And therefore, in the recent years, there is a clear preference for blended care. E-mental health can also play an important role in the implementation of what is called REM, routine outcome monitoring, by regular measurement of the complaint level and monitoring the effect of the treatment. As such, the treatment results can be made transparent, and on the basis of the interim results, the caregiver can decide to adjust treatment. After treatment or after the treatment, client accounts often remain accessible and continue to provide access to psychoeducation, exercise material, or other diary functions that are used, like a daily chart, for instance, that I'm using as an example. Many treatment programs even end with a module specifically aimed at relapse prevention. The client can consult various tips to maintain a healthy and a resilient life after the treatment. But as we are dealing with human matters in this webinar, I would like to touch upon a few experiences that we have gained with video consulting so far in this period of COVID-19 during the past year. First of all, we see that there is, due to the increased sessions of teleconsultation, there is a higher degree of fatigue for patients as well as for the professionals. And we see that this feeling of increased fatigue somehow dampens the dynamism of the consultation. This might result on a longer term with regular video consulting. It should not be underestimated because, okay, maybe you could understand that from immediate point of view, there might be no effect on the quality of the consultation. But as I said, on the longer term, we should look at this. Secondly, it has also been discovered that for some clients, a digital wall with teleconsultation has lowered barrier to talk about certain topics that were not discussed or not possible to discuss in normal consultations. Examples from that are person, sexuality, fantasies, or other thoughts that might have effect on the mental health. Another point of interest is privacy issues. In most cases, outpatient care was provided with the person at home, often revealing privacy concerns due to not being alone at home, which made the person feel uncomfortable to speak on openly. And in a similar context, it is clear that compliance with data security and patient safety guidance needs enough attention to put the client to ease or at ease to participate in a therapeutic teleconversation. But again, talking about human matters, the most striking difference that we have seen between a video session and a personal one is the above-mentioned dampening effect, and that in combination with the physical absence of a therapist. Now, we try to find an explanation for that, and a possible explanation for this can be found in the nature of a learning process. In a certain extent, a therapeutic process is also a learning process. And we can see, or we know that this cannot be exclusively attributed to only information transfer. Because in itself, there is almost no difference in information transfer between a video and a physical conversation. But the non-verbal communication and the facial expressions and other aspects are part of speaking to each other. The conversation between people is in fact a kind of physical process in which there is a kind of subconscious resonance between the conversating partners. And by this, as a human being, we get into a kind of deeper state of mind and subjective physical condition to the other person. And this process happens at an extremely high speed, reflectively and unconsciously. And therefore, the question arises whether we can realize this phenomenon, this reaction, this interaction during teleconsultation. And I believe personally that this is one of the many challenges ahead in video consulting and in e-mental health applications. So I think, as I said, it's a big challenge to find out if AI, artificial intelligence, and other technologies can be incorporated in this type of e-mental health applications. That's it from my side. Thank you.
Thank you very much for these deep insights. I think you spoke about facial expression, how to read the face. So one advantage of e-mental health is that you don't have to take a mask at COVID, because at least for me, it's terrible to communicate with people when I don't see their facial expression. And in the clinical setting, in this phase, everybody had his mask on. So I think that might also be a point why this interaction via telephone or via video can be really successful. So are there urgent questions? I just see a conversation here, but that's not referring to your presentation as I see it. So thank you very much again. We'll come to the points in our discussion afterwards. So now I would like to ask Stefan Heinemann from Essen to tell us about the challenges to the current digital health landscape. And we are curious about your presentation. Please start.
Thank you so much, Werner. Hello, everybody. Being a philosopher and study theology, but also having to do with the economics of healthcare. I'm pretty much interested not just in descriptive questions, but also normative questions. And what interests me is that obviously AI is shaping the world, right? It's like everywhere. And my question is, who will shape AI, especially in medicine? And that was my understanding of the headline of that interesting event here, Human Matters. Maybe one can say Humanity Matters. And well, that is not only important for what we have now, so artificial narrow intelligence, but of course for the great vision of artificial general intelligence. I'm a side note, I'm a bit indecisive on these questions, but I do think that there are no really convincing a priori arguments that a strong AI, artificial general intelligence, would actually be impossible. So if we do not ethically secure the future and also, of course, already the present of further development, so if you will, ethics by design, and the use of artificial intelligence, we might have a strong artificial intelligence in our lifetime with possibly reproach us for having created it. I don't know. We will see. But anyway, let's stick to what is possible today. Obviously, also artificial narrow intelligence as a concept and field of application of technology touches not only logical, technological, but also ethical and, of course, legal issues, especially in medicine. And that is not just true for science fiction. Significantly shapes our image of AI, but it goes back the past 3,000 years. So AI narratives are like firmly rooted in human cultural history. It's not new. So you find it in Homer describing self-pumping bellows and self-opening gates. You have that huge tradition of mankind being like fascinated by that idea. And in medicine, it is especially important because medicine and health is something everybody needs. There's no person in the world who does not need health or do not want it. And if so, the person is obviously not healthy. So actually everybody wants it, everybody needs it. And artificial intelligence and ethics in medicine, from my point of view, coin the ambivalence of technology as like a basic anthropological determination. Technical behavior is one of the most important anthropological basic characteristics. And for medicine, it's totally true. Medicine always tried to use what's there, what technologies can help, what technologies bring positive outcomes for patient in prevention, in diagnostics, in therapy, in aftercare, etc. And the reflections on this, on the use of technology and on the use of technology in medicine can be traced very early in the history of philosophy. What Plato coined being the techne plays an important role in the sophistic anthropology and is a central concept in the philosophy of Socrates, of course. So, and of course, the philosophy and the ethics of technology and the use of technology emerged much later. But this is what is, at the core, that on the one hand, man, we are all a product of nature and spirit. Thus, we exist, if you will, between reality and ideality, between is and ought. So we're a kind of weird mixture. And from an ethical point of view, it's of course very important to understand that the beginning of man lies in technology, his potential, and likewise. And that is also true, and especially true for medicine. The potential of AI, of data to cure, is immense. And it might be an ethical duty to use this as long as higher values are not threatened. And technology is a satisfaction of needs, but at the price of immediate new needs. We can do a lot of things in medicine to make life better with digital medicine, but it also creates new needs. And so technology becomes, as it were, if you will, a massive need in compensation of the no longer accessible needs. So being freeing man from nature, technology also binds him back to it. And that in a way is both, is a huge opportunity for medicine, but also is a little risk. And from my point of view, if we take care of certain points we can identify when it comes down to the usage of AI and data in medicine, like avoiding a bias, think gender medicine. We have enough crazy people. We don't need like AIs discriminate us. We can do it our own. And the AI divide, we have people that have access to the new opportunities in medicine. Majority does not, because they're not able to understand what is going on. They're not really free to access all that. They don't have the competences. There is this huge divide, as we see in the COVID crisis right now, like digital public health divide, if you will. And we have the jobs. We don't want the doctors to be replaced by AI, even if it would be possible, because only the doctors are moral agents, can held responsible for what they are doing and decide. That is why we have to make sure that they understand what the system decides. And it's not just a black box, so explainable AI. And we don't want the nurses to be replaced by robots, but what we want is the nurses to be paid fair. That would be a good thing. And we want to have trusted AI. So the EU, the big vision that we can have both economic success with good and trustworthy AI business models, and also not just ethical glamour, but real, true ethical values inside. That's the huge challenge. And medicine, from my point of view, is the huge, maybe the most important field of applicability. If we can make it there, we can make it anywhere. Thank you.
Thank you very much for these deep philosophical insights. I think when I took over this editor-in-chief role at with healthmanagement.org, I thought I would like to focus on the application of AI, and I think these issues are very important, and we are definitely shaping our future. We are shaping, as I put it in my book at Springer, the subconscious mind of our organizations, of our medical organizations. And we have to do this very deliberately. And we have to think about it, and we have to discuss it. And I think this will be a part of the program in the next years in the IT chapter. Yeah. So, but the decisive thing is how can we bring it to the clinical use, and that's a very difficult endeavor. And I think what we heard about e-mental health gives us a glimpse on how it can work, because e-mental health is mental health is the very personal part of health, and when we succeed there, then we will also succeed to implement these things in an ethical fashion in the other fields of medicine. So it was perfectly fitting to the presentations we had before. Thank you very much. So the next would be Begoña San José. I hope I pronounced it right. With a transition from surviving to thriving. Begoña, we are very curious.
Thank you, Werner, and thank you, everyone. So my name is pronounced Begoña San José. Most people call me just Bego. And actually, I run my own consultancy firm that is called Be & Go. And I typically support startups, many of which in the healthcare space and an increasing number in the mental health space, as my previous colleagues. So be wherever they want to be and go wherever they want to go. So be and go in a way. So what I challenge, I couldn't resist the temptation when health management put up the topic of health matters, because I believe that bringing human matters back to health is really important. And I'm going to focus on that back to health part of the sentence. And I'm going to be guiding my presentation with some quotes from wise people before me, if I may. And the first one starts by saying that it's not the strongest of the species that survives, nor the most intelligent, but the ones most adaptable to change. And that's Charles Darwin saying before me. And why do I start with that sentence? It's just to reflect that we have been able to sustain a healthcare system that continues to survive, although is not yet at the level that we would like it to be. The second sentence that I will use to guide my flow of thoughts is that the best way to predict the future is to create it. And this is Abraham Lincoln. And we have an unprecedented opportunity to create the future for health. And the third one that I'm going to use is from Maya Angelou, which is in a very different context, of course. But if we are always trying to be normal, we will never know what awesome can be. So my challenge here is how can we create the healthcare of the future, and how can we create it not normal, not a new normal, but an awesome future for it. So what I did in that respect was to reflect first on what was health like in the old normal, if I may quote unquote. And the old normal was, and I'm looking at it from 3 points of view. So what was the definition of health? And in the old normal, the definition of health de facto was merely physical health. Nobody talked about mental health before Corona, okay? Or before COVID. The healthcare system was a healthcare system focused on symptoms, tests, and prescriptions. And healthcare professionals were taken for granted by health, by the way, and they had a snapshot of a patient for the minutes that they were interacting during the practice, okay? What happens with the pandemic, when the pandemic comes on, then we start thinking differently about health, and we don't take it for granted anymore, because we realize, like in the fairy tale of the milkmaid and the pail, that without health we cannot do any of the things that we had planned to do when we had health. We cannot work, we cannot go to restaurants, we cannot see friends, we cannot. There are a number of things. We cannot, our career doesn't matter anymore when we don't have health, our family doesn't, it became the topic, and we started realizing that, hey, without health, there's really nothing else. The second thing that happened with the healthcare system during the pandemic and during this long tunnel where we're seeing the light at the end of right now is that the system had the ability to adapt and to adopt some of the changes, and it gave priority to managing the physical health pandemic wave and create capacity out of nothing, and try to reallocate resources very quickly and get everybody equipped with masks and so on. And mental health, as my previous speakers highlighted, was put on the spotlight. Healthcare professionals is an interesting topic as well, and actually even health management also had a dedicated issue last year on the heroes of the crisis, because they were taken for granted before, and now they were elevated to the category of heroes. I was vocal myself when I said that that is not very fair, because I don't know many heroes that are tired and scared in front of a virus, and doctors were exhausted and they were really scared, and they put themselves and their own health and that of their families at risk for all of us, to be honest. Yeah. So it came from being invisible. They are there when we need them. We don't care otherwise, to being the heroes of the system, and to put their own health at risk. Now, when we have the unprecedented opportunity to make this a new beginning for health, we should not conform with making it the new normal. I resist myself, and I encounter a lot of people that resist in doing that. So what would an awesome healthcare system look like is my provocative statement. Then I went into looking at the three aspects that I've been highlighting. So what is health in an awesome future for health? Well, it's typically, and I'm saying that I wanted to go back to bringing human back to health, because it's physical, social, and mental well-being, and not the mere absence of disease. Now, what happened? This is a theoretical definition of health that we have had in WHO since its foundation, but that we have de facto forgotten or left aside in a way. Okay, so when I look at health and how does an awesome future for health start with? It starts with physical, mental, and social being a holistic part of the definition of health, with fulfillment, resilience, confidence, and I don't know how many of those words being part of what we humans are about when it comes to health. If I look at the healthcare system, it goes certainly beyond tests and beyond vaccines. And let me tell you, there is no vaccine for the mental health consequences of the pandemic. Let me tell you that there is no vaccine for the social consequences of the pandemic. But if we are taking health as a physical, mental, and social well-being, and not just the mere absence of disease, we are missing the elephant in the room, if I may. Okay. Now, again, the previous speakers mentioned artificial intelligence, and I do believe that technology-enabled healthcare is possible. But I think that, and I do respect and appreciate all the comments on privacy and how to set it up to be fair and to build or be part of the building block for a better future. I believe that tech would also enable healthcare to be emotional intelligent. I think that the key characteristic when we're trying to define the awesome future for health is not so much artificial intelligence, which for me would be an enabler, but an enabler that release resources for an emotional intelligence system. Because when we want to a doctor, we don't want, or when we address a healthcare professional, we don't want to see just numbers and algorithms going behind us. We actually are looking for the human behind that system as well. So when I reflect on the healthcare professionals, and if I take seriously the definition of health as a holistic well-being in social, physical, and mental dimensions, then I'm talking about everybody basically supporting that. And I believe a healthcare system that goes beyond the hospital wards and goes beyond the doctor's offices, and it goes everywhere. It goes to human living, to schools, to universities, families, work, supermarkets, restaurants, friends, everywhere. And a system where everybody, or a lot of people, a lot more people that currently are, and maybe we need to talk about the reallocation of resources again, that are contributing to our health, not only preventing it from getting worse when it happens, that would be secondary prevention, but preventing it from happening in the first place. And we're talking about mental health, and we're trying to fix the anxiety and depression of today. And one of the things that I think we need to look at, and we probably need to break a few silos in doing this, is getting children and adolescents the tools to self-manage their emotions, to cope with stress to start with, to incorporate social well-being. And instead of that, what we're seeing is we're cutting off art classes in favor of more mathematics for students, especially with this corona. So I think that we need to put it back in the right dimension, take it seriously what we're talking about, and health is what really enables us to do everything, as we realize, and we have the opportunity to take that forward to create a much better future for everybody. Thank you.
Okay. Thank you very much for this very broad view. What we heard before from the philosophy point of view, we heard now from the society point of view. And I remembered one saying in Austria, they said health in all politics. So that was, I think, more or less your message. So thank you for that. So the next would be Sara, Saeed Khurram, and she will tell us about the lack of female participation in the healthcare. I am very curious because when I look at the Austrian healthcare system, then we have much more female workers, but not in the management level. So I wonder what you are going to tell us. Please take over.
Thank you so much, and it has been a pleasure listening to you all. Very, very excited for this because I think what I work for back in Pakistan is very resonant from the topic of discussion today, that humans matter. So you said that the Austrian healthcare system has majority of female health workers, and I'm sure it's mostly the case with a lot of countries in the world, and it is no different in Pakistan. So I come from Pakistan, which is located in the Southeast Asia, and I'm a medical doctor by profession. And the purpose of my being and my passion is to bring back doctor brides back to work. So if I can tell you a little bit about what doctor brides are in my country. So Pakistan has around 200,000 doctors, which is where I come from, and we're a population of 200 million people. We're the 5th largest population in the world. So we have one doctor for 1,000 people, which is the minimum WHO standard, not so bad. 60% of our medical workforce, and even more, is female. 60% of our total healthcare workforce is also female, including nurses and midwives. But unfortunately, between graduation and formal practice, only 23% women actually come to work. Rest become doctor brides, which means that they get married, they have children. And the only reason their parents made them a doctor was so that they can get a better hand in marriage. So if you're a female in Pakistan, if you're tall, if you're fair, if you're pretty, you get the best hand in marriage, you're settled. But unfortunately, after marriage, you can't go back to work because you have to choose between your career and family. And that unfortunately happens to 2/3 of our female healthcare workers and doctors in Pakistan. Pakistan is also a country where a lot of people leave because of better work opportunities. It's a third world country, so a lot of doctors leave to US or UK for better work opportunities. So 25,000 doctors leave every year. So in short, we have 90,000 working doctors for a country of 200 million people, which means now we have one doctor for 1,700 people, which makes it extremely difficult for any healthcare system in the world to physically provide doctors to patients and quality healthcare. And I realized it in my life, and I became a doctor bride around 7 years back. I had a baby, I moved to a new city, and I couldn't work. And and that pushed me into postpartum depression. And just to get out of that, I started doing consultations on call in a clinic, which I used to work for before my pregnancy, on call. And once we started doing clinics on call, we realized that unless I see the patient, I can't develop the rapport. So we started doing on call or telemedicine consultations. And that's when, I got the idea that if I, being at home, can provide consultations to patients in a far-off community, why can't we get all female doctors in Pakistan to do the same and fill the gap of doctor-to-patient healthcare in Pakistan? Because I briefly mentioned that Pakistan has around 200 million people, but another very startling stat for our country is that half of our population never gets to see a doctor in our lifetimes. 100 million people don't see a doctor. They see a quack or a midwife or a dispenser or a compounder, but they don't see a qualified doctor. And women and children are disproportionately affected. So 1 out of 5 children in Pakistan do not see their 5th birthday. 26% women die while delivering a kid in our country. So we took up a simple solution to a very complicated problem and merged it through technology and created the company that I run in Pakistan called Sehat Kahani. Sehat means health in Urdu and Kahani means story. So it's the story of health that we're trying to change in our country. That we created an all-female doctor-provider workforce that can provide consultations to patients in far-off communities who have never seen a doctor in their lifetime. Now, I'm talking about a country where, when I started, there were around 15 million smartphone users, 18% in internet penetration. So when I started doing telemedicine in Pakistan around 6 years back, every door that I went to knocking for help said that this is not possible. A female doctor sitting at home cannot provide consultations to patients in far-off communities. And we struggled for 4 years pre-COVID to make our mark. We started by making clinics in low-income communities when nurses were sitting and when patients came in, they connected the patient to the online doctor. And we kept making these clinics for low-income communities. We also created a mobile application for urban users, for smartphone users that allowed you to connect to a doctor directly. All of this happening through telemedicine. We worked on physical healthcare. We worked on mental healthcare. We created clinics after clinics, but still in my country, when I talk to someone, there was always this hesitation that how can a doctor talk to a patient on a video call? How does that happen? Because in my country, until the doctor touches the patient, they think that quality is not being met. And then COVID came in, and I think it has, in my lifetime, this 1 year has revolutionized how healthcare was being perceived in a country like Pakistan, which is extremely traditional, extremely patriarchal, extremely conservative. From the point that healthcare could not happen without touching or feeling, healthcare could happen through a virtual doctor, as we all saw it in COVID. And the platform that I created and the power of female doctors that we built over these last 4 years with 5,000 doctors in the network just became this platform that everyone could access 24/7, that people in low-income communities could access. And suddenly, all those barriers that we had pre-COVID started to break down. So we partnered with the government in Pakistan and provided free-of-cost consultations all throughout COVID. We provided our application to ICUs across Pakistan to connect junior doctors to critical care specialists. And just to give you some context, Pakistan has only 70 critical care specialists for 200 million people. So our app could connect junior doctors to senior consultants all over the world. We provided our application into other third-party applications so that their members could connect to it. We provided our application to corporations so that they can give their employees the benefit of telemedicine coverage in COVID times. And we created 7 different verticals by which a network of female doctors using a telemedicine platform that connect to patients and provide healthcare. Just to give you a little example of what we saw work as a power of female healthcare workforce, if given equitable opportunities and flexible opportunities, what they can do. So we had a doctor on the platform who was expecting, and she provided consultations till her date of delivery. She delivered her daughter, and on the second day of delivering her daughter, she was back to work doing consultations for patients from her bed when her baby was beside her. So I think that's the level of commitment that we saw from the female doctors once they were given flexible opportunities. So I think one thing that I've learned after doing telemedicine in a country like Pakistan is technology, as Bego said, technology is an enabler. It connects the patient to the doctor. It provides more opportunities for patients to access doctors in different settings, because I belong to a country where there is a terrain of thousands of kilometers where healthcare facilities are not available for patients to get into, and they have to walk 5 or 6 hours to get a single doctor consultation done. So healthcare through technology really allows accessibility and equity when you want to reach out to a doctor. However, what I've seen is what makes us different and what makes us unique and how it will catch up to physical healthcare is if the doctor is talking with the same empathy to the patient as they would physically. So you can bring any technology in the world, you can make it very, 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 you can make it extremely unique. But until the doctor is asking the patient, how do you feel? What do you want to talk about today? Whether it's through a virtual background or through a physical setting, it does not matter. An average doctor-patient consultation in my country is around 1 minute and 20 seconds. On our platform, an average consultation is around 18 minutes. And when we do a feedback, the only thing that patients say was, when they give a good feedback, they say that the doctor talked to us nicely, they had a smile on their face, and they really cared about what we were talking about. I also belong to a country where there are only 400 psychiatrists and psychologists because there was a lot of talk on mental health care. Now, imagine in the context of 200 million people and 400 psychiatrists and psychologists, how can you fight that battle without taking mental health through telemedicine into account? So as we build telehealth services, we see a lot of companies doing the same in my country for mental health, because Pakistan and mental health and treatment for mental health is very, very stigmatized. It's a huge taboo to talk about your mental health issues. I'm sure it's globally as well, but you add another layer of patriarchy and cultural conservativeness to it, and it just makes things more complex. So in my experience, I think telemedicine and health innovations in technology is a great enabler. It provides flexibility to the people who want to provide healthcare. It provides flexibility to the patient. It is cost effective, and it creates equity. In my country, if a person is sitting in a rural village or sitting in an urban city, they both can get access to the same doctor using technology, and they wouldn't have gotten that opportunity in their lifetime if we only had physical health and space. So I think it's extremely important. It's very much needed now, and we hope to build a platform that allows female doctors from wherever this problem exists, that women cannot work after certain hours or during certain times of the day. I think this platform allows a global network of female doctors to come together and help many patients. Thank you.
Thank you very much for these insights for European standards, completely inconceivable situation you're in. And I think what you did with your engagement is helping to leapfrog the healthcare system of your country. And I think it's really astonishing how you can move and how you can change things in such a paternalistic society like a Muslim society, at least for Europeans, seem to be. So congratulations for that, and really great job. So that leads me to the last panelist. We are soon running out of time, so the discussion will be not so long, I guess. So please, Habeebul Rahman from Singapore. So we are really international here. And I think he's going to address the supporting of the well-being of the staff. So the human matters that especially at least in Europe, in COVID, where the workload was tremendous for those people. They were named heroes, but some heroes are forgotten soon, especially in the care, in the field of care. So we are looking forward what you are going to tell us how it is in Singapore. Please take over.
Thank you so much for this opportunity to share. And as a psychiatrist, I'm really heartened by all the stories that I've heard today. And I think mental health is front and ahead, and the champion of people and trying to get technology in to really help the people who are delivering care to other people. And I think that's the heart of what we do. So Singapore is a small country, but we had COVID come to us in a way that we were really not prepared for. We have a population of about 5.6 million, by no means, able to match any of the big countries. And the hospital in which I work in, which is in my background, if you can see, looks after a central region, and we care for about 1.4 million people. And we have a workforce of approximately 12,000. Now, what's really important here is that our hospital is twinned to the National Center for Infectious Disease, which was completed just months before COVID struck, which is the equivalent of the Communicable Disease Center. So what we had with reference was the SARS epidemic in 2003. And, you can only prepare for what you know. And what we prepared for when COVID struck us in January of 2020 was based very much on SARS. But as we know now, I think the game is entirely different. And what I think helped us move forward with helping our staff the most was something that we've already mentioned here today, which was essentially agility. But that agility needed to be built on a pre-existing structure of relationships. And these relationships actually had their seeds planted as far back as 2003, when what we realized was, as healthcare workers, I think we are vulnerable. We put our families at risk because of the work that we do, but not going to work to help is really not an option. As much as we might be celebrated as heroes, I don't think anybody thinks of themselves as a hero when they show up to work. It is simply the thing that you do. But what was so difficult at that time was being separated from your other friends and colleagues and the other healthcare workers who used to work right alongside you. So what we had were, caregivers, workers, doctors, nurses, therapists, all having to work in silos, very much almost in isolation rooms where they would go in, offer care to their patients and come out. And in those situations, we found that, all healthcare workers, after a while, bore a tremendous emotional strain, and they really needed help. So what came out of that was a peer support system, and that was in 2003. And over the years, what we developed was really a whole superstructure to look after staff, because peer support is wonderful, peer support is great. But when there's no crisis, I think what happens is everybody sort of gets into a normal rhythm, and the peer support levels evolve into something that is structurally embedded and that goes into friendships, into relationships that develop within departments. And that was really important because we needed the strength of that when COVID struck us, and it pushed all our preparedness to the next level. And in the article that we've written for you, what we have described is actually a way to conceptualize how we look after our staff on the ground via three main pillars, if you will. Now, the first pillar of our well-being efforts is that of what we call care. It's basically the part of us that gives back to our colleagues and to our friends. And it encompasses that very important psychological component of being able to provide counseling, to be able to provide emotional support, to be able to provide a listening ear to any staff that needs it at any time, and also to be able to escalate it in a way that is sensitive to their needs and that prepares them to be able to go back to work, essentially, so that they can carry on doing the work that they've been trained for and that they're recognized for. In addition to that, what we also needed was, someone who was embedded in each and every department, because there was no telling when it would be that we will be separated from our friends and colleagues. And for that, what we created was the role of something called the welfare officer. Literally, so every department, clinical, administrative, had to come up with a name. And what we found was actually there were people who were already functioning in that role, that person that buys birthday cards and cakes and, who is that glue that holds the department together. So what we did was we formalized their function and we recognized them. We also leveraged on technology. And that's what makes it so interesting. It's almost like when this pandemic struck, it was at a time when the technology was there to enable us to manage this pandemic. And so we were developing bots, we were developing apps that could deliver on the go some form of almost internet-based CBT type of application interventions for our staff. So if, let's say, somebody was in full PPE, you couldn't talk to your friends, you were alone, you had your handphone, you could get psychological help, right? So care was so important that it needed to be delivered in a way that was structured, that could be escalated, and yet could be personalized and could reach anyone, anywhere, whilst they were providing care to their patients. Now, the second arm or second pillar of what we conceptualize is something called protection. And we realized that our staff, they needed protection, not just in the form of physical protection from their PPE, but in situations where human lives were at stake. I think emotions run high, and they were at risk of facing some forms of harassment or abuse where they work. And this abuse is something that I don't think we talk about very much, but it is there. And I think the message that we sent out was, you do not need to suffer in silence. So we had a staff protection committee set up, and this was strongly engendered by the nurses, by our quality, department. And what we did was we ran drills to enable staff to be able to respond in a situation, almost like muscle memory, so that when they're faced in a position that they felt uncomfortable, they will be able to respond appropriately. And of course, we created policies to go along with that. So that would be the second pillar. And very quickly moving on to the third pillar, and this is where the concept of wellness comes in. So we've got care, we've got protection, but what actually drives the agenda where our staff are able to thrive, to be able to move forward, are able to, achieve, further levels of development, not just within themselves, but for their department as well. And that's where human resource wellness comes in quite strongly in terms of the events that we were able to organize for our staff, because we were receiving lots of goodwill. How would we distribute that goodwill? How would we show to our staff who were working with patients that the rest of the country was actually behind them and rooting for them and celebrating them? So we also thought that we needed not just psychological support, but actually physical support as well. How do we get our staff to exercise when they are isolated? How do we get them to do a bit more when they get home and they're really tired, they need their sleep, they need their rest? How do we get them to look after their health as well? So that's where human resource wellness comes in. So if you put all of these together, these three pillars, what they needed to do was work with not just a top-down approach, i.e. from the leaders emphasizing care for staff, but also enabling a sort of bottom-up approach. And what we saw in the last 1 year is essentially lots of little bits of improvement, of activity, of ideas coming up from the ground. The nurses coming together to create something. We had something called the Spread a Smile movement where, we're all behind masks all the time. How do you know you were smiling? Well, believe me, we were. So when we saw another staff and with our eyes, we'd communicate how much we appreciated them, but we translated it into something called the Spread a Smile movement, and it took off tremendously on Facebook at workplace. So enabling a top-down care approach, enabling a bottom-up innovation approach, and mediating that in the middle with communication, with agility, and with digital platforms in which we could communicate with each other, even though we were separated. So I think that in a nutshell was all the efforts that we put into place. I think we're in a position where we're not sure how much longer this is going to last for, but we hope that we've got the right ingredients to make this succeed. Thank you very much.
Okay, thank you very much for this focus on those who worked for us in COVID, who worked for the sick people. Thank you for this focus on the staff, on healthcare staff. I think we had such a broad approach from all this presentation to this topic that it's very hard to get to a discussion now. So what would be the questions we should discuss? And I just see that they have opened the schedule for us until 5:30. So we have 15 minutes left. There are no real questions to all panelists there, as I see. Is from the panelist side who experienced those presentations here. Are there additional remarks from your side that you would like to contribute? Please open your microphone. Begoña.
Okay, thanks for the opportunity then. I read with great interest both Erik's and Mette's paper before the conversation today, because I said, well, most of it happened to be mental health at the end of the day. And I would like to reflecting from some of Erik's points, for example, on silence, and how silence is interpreted different in a face-to-face intervention where the patient has the safety space to feel, and how does Mette, from the experience maybe of your tele-mental health approach, take that into the virtual context where sometimes silence is interpreted either you are in mute, the connection was lost, and we actually started our conversation like that, or any other way. Have you also that type of experience that you can share with us?
Well,
okay.
I also read Erik's article with great interest, and I know him and his work well from collaborative projects. I don't work in video consultation, so I haven't experienced this myself. But what I understand from my colleagues and also the people who research this area is that it is very different to consult with the patient online, and there are these differences in how you interact. But there are also ways to go around that. And what we see in the research is there is no loss of effect. So we still get the same clinical effect. And the experience might be different, but that's also where we're intensifying our efforts to train our psychologists to use this new medium, because the treatment is the same essentially, but the video is a new medium and it does require something else from them. So it's something we're attentive to. Definitely, but to us, it's very important that we don't see this loss of effect.
Mm-hmm. So I think it was a huge collective experience, this COVID crisis concerning healthcare. I wonder what we make out of this, and maybe discussions like that and contributions like you made in the last journal really helps us to get along there. Erik, did you want to say something?
Yeah, I just wanted to add to Mette's comment. I think, or I suppose, or it is, I would say, that you had already done that research in Denmark, and probably you are already far away in these studies and using telepsychiatry, but I would say the basic or the resources where I got my information from is, on one hand, okay, I don't have myself that much of experience with video consulting, but I have a lot of contacts with peers, yeah, and mainly in our countries, Belgium, Netherlands, and the neighbor countries. And I know from experience that the Scandinavian countries, in general, they are a little bit a step ahead in the e-mental health. So I think it's very interesting to hear from Mette now that there are some research that there is no loss in therapeutic effect. But okay, at this moment, it is not, I would say, not all therapists, not all psychiatrists have enough digital skills or skills to work in this way of giving a consultation. And now, due to COVID, this came to quite a big speed. Everybody had to do it, and not everybody, few people were in fact trained to it. And that's where came in that one aspect of silence is, if you are not used to get this kind of silence in a video in a consultation, you have that in a physical consultation, with that I have experience during a normal consultation. Silence is a very important one, because then you are physically in contact in contact with your therapist, and there's a lack on that in video consultation. But once again, if you are making research or have made research, I'm very interested to read that or hear about that. But so far, I just want to address that it is not the case in all countries, and for sure it is not the case with all therapists.
Mm. Okay, thank you. Begoña, do you wanted to add something?
Yeah, I can just add the comment of the golden standard in healthcare, in mental health care especially, is not necessarily best practice possible today. So many, because of the shortage of healthcare professionals in the mental health space that we all have pointed out in one way or another, the golden standard against which we are measuring is still not ideal, because still a lot of people don't have access to the needed mental health support that they need. And the ones that do under less than ideal circumstances in terms of time constraint, in terms of finance constraint, on whether it's covered or not covered and whatever, and especially in some countries because of taboo or other social questions as well. So I think that one of the important questions which I undoubtedly support is the scientific evidence behind it. I think we have to take it one step forward, because a lot of people that did not used to have access to mental health care now have access to it, and that certainly improves, but we need to continue and going towards a much better system down the line. That's it was just a remark. Thank you.
Okay, so I think it's. I will try to sum it up somehow, though it's fairly impossible. But what I took from this interesting panel is that the digital technologies were in place and in healthcare not really used. And COVID drove us and pushed us to use it. So we were not perfectly educated for it. We had to improvise. We needed the human abilities to make improvisation, to be creative, and like we heard from Pakistan, to help leapfrog the system, to really disrupt the system with telehealth, and by the way, bringing a woman back to work again. So the technologies were enabler for human abilities to thrive and to move our systems. And I'm with Begoña. We will need these abilities for the next crisis to come up, and that will be maybe a social crisis. And we all know that social health is a pillar of health, and disease is often associated with poverty and so on. So now we are on a political level, and it will be a big political task in Europe, but also in other countries, to manage this process of consolidating the society again. there the digital technologies can be of help, but it's a big political task. But it only will work if there are engaged people behind, people like here on the panel who in their field try to move on, try to make innovation. And I think that's very important to exchange those views, to exchange those experiences. And that's why it was really worth to make this panel. And frankly, when I read Human Matters, and then Christian Marold told me you should moderate this round, I thought, my experience as Chief Information Officer and as Chief Executive Officer, well, let's try it. But it was really a valuable exchange of experiences, and maybe Pakistan takes some ideas from Europe, but I think it's really a positive experience, and I'm looking forward to the next panels that we make. And I wish you all the best in your profession and in your work to cover up all that what COVID has left to us, or the challenges COVID still poses on us, and so that in the long run we have a better social and better healthcare system in our countries. Thank you very much, and let me close this session. Hope to meet you again.